Good afternoon, Dr. Bourne. Thank you for joining us for the podcast today. This is a conversation I'm excited to have, as I know there's just a lot of confusion about menopause, everything from what it actually is to whether hormone replacement therapy is safe and effective. We've got a lot to cover, that's for sure. Before we dive in, though, would you mind just running us through your background, your origin story, as it were, and how you got into this space to begin with?
Yeah, sure. And thank you, Rob. Thank you for inviting me. I'm Dr. Sarah Ball, and I am a medical doctor, so trained at medical school and became a GP as quick as I could. I always wanted to do kind of general stuff, but I always lent towards the female side of medicine and women's health and contraception and things. And I qualified as a GP in 2002, the summer of 2002, which was it was 3 days before this big trial that I'm sure we'll go on to talk about was suddenly broadcast to the world about how unsafe HRT was, having previously been thought to be the best thing since sliced bread. So it's literally, as my career started, menopause kind of became something that people stopped talking about and were scared of and were confused about. So really just through my career I carried on being a GP. So I was a GP for 20 something years, and just found myself feeling, although I was keeping as up to date as it was possible to be with women's health, including menopause, it almost felt like we were living in the dark ages. We could manage all other conditions really well with all this evidence and trials going on and great big conferences and all sorts of things, but it felt like we were quite behind. And then the National Institute of Clinical Excellence guidance came out in 2015 and kind of slightly started to turn the corner a bit in terms of, actually, there is a chink of light that we could maybe start to improve menopause care with. And so in 2018, then I started to also do private menopause work, and I trained with the British Menopause Society, so I'm an advanced menopause specialist. And so now the demand for that private menopause work just absolutely skyrocketed. I mean, exponential doesn't even begin to cover the demand for it. And so for the last 6 years now, I've done purely private menopause work. And so you really get a chance then to dive into it in a much more deep way and to really focus on the extraordinary extent that it has been neglected. We've sort of had 20 years of neglect, and it's trying to bring everything more into the 21st century and actually support the half of the population that are going to be directly affected and the other half of the population who are going to be indirectly affected also. So I now work at a clinic called Health in Menopause. It's the most wonderfully rewarding job because it feels like finally after a drought there is help that we're allowed to give and that the public are now more receptive to, thanks to lots of conversations now happening in the public arena. So that's me.
That's perfect. Thank you for that. I'm glad you mentioned the NICE guidelines. I'm sure we'll get to them later. So I reckon we might as well dive straight in. And thank you for that introduction. It really sort of covered a lot of bases. And ask the obvious question, which I suppose, what fundamentally is menopause, and how does that differ from sort of peri and post-menopause? I know many clinicians will sort of refer to menopause as a single day, but could you break down what these terms mean and then walk us through maybe some of the common symptoms that one would sort of associate with menopause that are oftentimes put down to maybe other life circumstances that women and especially men will often miss.
Yeah, absolutely. And you're right. It's trying to pin down the definitions of the words can be confusing and tricky. And I would still say that menopause is one day in a person's life, a person that has had ovaries, or still has ovaries, but they've stopped working or they've been removed. So it's that one day, if you're having a naturally occurring menopause where your follicles, the parts of the ovaries that can produce eggs, have stopped working, and you've gone a whole year without a menstrual period. So it's that one day, but unless you have a surgical menopause or a menopause that's induced by some kind of medical procedure, which can be quite sudden, most people's naturally occurring menopause doesn't just happen. It takes anywhere between 2 and maybe 12 years for the build up or the decline in the ovaries to actually then become them not working anymore. So the average age of menopause is 51. So that means a woman could be starting to experience some issues with changing hormones while her periods are still going on, and she may be just in her late 40s, but she might actually be in her late 30s. And so we have this usually decade, which for most of us is in our 40s, where there could be all sorts of shenanigans going on with symptoms and health complaints and life happenings. And previously we didn't, my sixth sense and other clinicians' sixth sense was there's got to be some hormonal involvement, but there wasn't a kind of permission to call it something and to actually then be able to, give it a label and therefore be able to start to help to manage that. So we have this perimenopause, which previously was really poorly understood, really, and is probably what I would say is the biggest change or the biggest sort of light bulb moment where you go, oh, right, okay, yeah, that really helps. If all medical doctors knew that would be really helpful. And then you have this one day, which is your menopause, and then forever after you are postmenopausal. So you could have your menopause at the average age of 51, and then if you live to 100, well, actually, for 49 years, you are postmenopausal, and there can still be issues arising because of that. So it's I think convention or history has sort of taught us that menopause is, a couple of years, maybe of a few symptoms, done and dusted, move on. But of course, it really, really isn't, because for the average age of women in this country anyway at the moment, if lifespan goes to sort of 83 to 84 years, then actually you're going to spend about 50% of that of more, if you start from the beginning of perimenopause, which from maybe average is sort of early to mid 40s, then that's a hell of a long time to not understand what's going on with your own body, and to risk that your health professional also doesn't understand what's going on with your body. Symptom wise, I think this is where another big area of confusion is that there's so many symptoms and they can start all at different times for different people, and you might have completely different symptoms to your sister or your mother or your friend or your neighbor, and so it's constantly trying to join the dots. So there's maybe the slightly better known symptoms, or the more kind of physical symptoms, the symptoms that people find a bit more easier to talk about, which would be things like hot sweats, flushes, fatigue, maybe headaches, migraine, joint pains. Actually, joint pain is worldwide is the commonest symptom of menopause, but again, not a lot. But everyone thinks it's hot sweats and flushes, but actually only 3/4 of people will ever have a hot sweat or a flush. A quarter will never have one. Yeah, doesn't mean. Yeah, so it doesn't mean they're not suffering in other ways. So there's the sort of physical, poor sleep. Sort of physical symptoms, but then there's the genitourinary symptoms, which people struggle to talk about often because it can be slightly more embarrassing. So
Vaginal dryness, things
yeah,
like that.
vaginal dryness, the vulval dryness, the bladder issues, the lack of libido. So that's a kind of a tricky thing to talk about, especially if you're still in your 40s and you think, things are going a bit wrong down there. It can be a difficult thing to talk about. And then there's the emotional symptoms. And actually, of all of the symptoms, I would say it's the psychological symptoms which are the most troublesome to women that would come and seek help. And it's the unexplained anxiety that comes in midlife for no apparent reason, or the feeling overwhelmed with life when previously you were able to kind of
That massive
manage.
drop off and gather.
Yeah, absolutely. Yeah, the paranoia, the rage, and that's real and scary for some women. Is the lack of the losing self confidence and self esteem. And
It's delightful being female, isn't it?
it's an absolute, it's an absolute challenge to navigate. I mean, I often think, well, we have this, for many of us, luckily, this amazing ability to reproduce. But there's a hell of a lot of complicated biology going into allowing that to happen. And then, of course, when even if it starts to not work in the proper way, that's challenging. And then, there's extremes of that. So there are some women who sail through the menopause, and that's wonderful. But there are literally some women who it's the start of the end in terms of physical symptoms could just be completely overwhelming, or it could be the start of the decline of their future health, because menopause not only affects you in the day-to-day sense, but it affects your future health and wellness. And it changes people's lives. It takes 1 in 10 women out of their job because they can't cope anymore. The highest divorce rate is in females in their 40s because the relationships become more challenging. People literally, you see some people, not everyone, some people fall off their perch completely at menopause. Someone that was very capable, very managing life, multitasking, absolutely confident and fine, and just becomes a different person, and no one previously really understood. They were usually just treated as being depressed, or their individual symptoms were treated. They might be sent to a cardiologist because they had palpitations, or they might be sent to a neurologist because they had migraine, or sent to a gastroenterologist because their bowel habit changed, or whatever. And what we have to get so much better at doing in medical profession is joining the dots and going, actually, have we thought about whether there could be a common cause that's linking all these problems rather than seeing them all as the individual issues?
Yeah, no, I mean, you touched on a lot there. I'd love to come back to what you mentioned earlier about a woman sailing through menopause. In my experience, well, not that I have much experience in this respect, but I find that women who do transition sort of more easily through this period in life are generally healthier to begin with. And I'm sure we can discuss some of the lifestyle factors later. Do you find that to be the case? And then sort of on a similar note, what do you make of this notion that women are sort of entering menopause sort of at an earlier and earlier age? I mean, that's a whole rabbit hole in itself. Obviously, we could have a whole podcast on that. But do you think that there are any sort of environmental factors that might be, if it is indeed the case, sort of speeding up the sort of transition into menopause for some women?
I mean, we know that, for example, smoking tends to bring on menopause on average 3 years before it would otherwise happen. When we are not looking after ourselves properly, and of course in this modern world that's very difficult. So with yes, on the face of it, we're talking about getting a good night's sleep, doing regular exercise, eating healthy foods that are nourishing, but it's we know it's increasingly harder to do those things these days with all the financial strains on people, and people trying to be a million people to and have a million roles. So, and I think, we've always underestimated the role of stress in all conditions, haven't we? And, and the cortisol and how that's going to affect how we make our hormones in the first place, and things like that. And there's so many things we don't understand, and how other medications that we might give. So, contentious issue, but, we give out statins now like Smarties, but actually is there an argument that if you give out statins and you decrease cholesterol, that therefore you're going to make less reproductive hormones? And so sometimes we're robbing Peter to pay Paul. So yeah, and I think we have a lot more, in a way, there's a positivity in that we have, with childhood and teenage cancers, for example, the treatments for them and survival rates are now much better. But for the females that are suffering those cancers, they will go into often a risk of going into an early menopause. So we have a lot more. We used to always quote, I always used to say, 1 in 100 women under the age of 40 will be in menopause. And there's unexplained reasons for that, but for some reasons there is an obvious medical treatments for other conditions has caused that. But actually now we've redone the figures, it's actually 4 in 100. So 1 in 25 women will be in menopause before the age of 40, sorry. So it's not a really uncommon problem. This is everybody. So it's really trying to shine a spotlight on it, and not only for women themselves, although that is the most important thing, but actually for society in general, and for economics, social economics. If women become less productive because they are suffering around their perimenopause and beyond, then that has a real knock-on effect on their work and their employers, and the GDP and all of that. This is a much bigger thing than just medicine.
Yeah, I love you sort of brought up stress. I mean, I sort of, as we were talking about off there, this functional medicine approach, and even within that sort of paradigm where you sort of take a very sort of individualistic approach to treating these sorts of issues, I think a lot of practitioners will sort of overlook the stress component. And when you sort of start to look at how stress affects biology and how it starts to create high levels of inflammation that then sort of force cells into these states of sort of being inert, essentially. It's not surprising that we're sort of seeing that these sort of broadly speaking, these endocrine problems in general. I mean, the same thing obviously applies to men too. I think, well, I know that, what's the easiest way to put this? If you want to put someone through hell, completely mess up their endocrine system, and one of the fastest ways to do that, short of sort of chugging plastic-laden water, is to just be under this constantly high-stressed state where your body is fundamentally put into a state where it is no longer worried about reproduction, and where it is no longer worried about these hormones, and it's just worrying about getting through each day as it comes. And as you've alluded to already, I suppose it's actually nature's sort of cruel irony, ultimately. The moment a woman has sort of transitioned through her childbearing ages, she evolutionarily, quote unquote, has no purpose, said very delicately, and all of a sudden, as an individual, you are just sort of left in this state where life is untenable and can be unbearable. And I think, which is why I'm sort of excited about the initiatives that are starting to come out with regards to endocrine health in general, specifically for women, because for years I think it's been far more acceptable as a man to go to your doctor if you have low testosterone, and they'll say, we'll stick a needle in your ass once a week and problem solved. But for women, it's been, I don't know why, but the uptake has just been much slower, and maybe that has something to do with the Women's Health Initiative, which we'll discuss in a moment. But anyway, Dr. Paul, I'd like to pivot into talking about how you treat patients in a bit, both in terms of HRT and whether you think there's space for some of these natural remedies as well, things like black cohosh and red clover extract, etc. My feeling is that these molecules, these supplements, they can help maybe manage the symptoms, but because they're not really replacing anything, they're not going to support an individual from a sort of a longevity or a health span perspective. Before we jump into all of that, though, I'd like to talk what I've just about what I've just mentioned, which is the Women's Health Initiative, as I think it really set back sort of the HRT space, specifically within menopause, by a good 20 years or so, if not longer.
If not longer, yeah.
Yeah. So, but yeah, I'll hand it over to you because I'm not well read in this space, but I have a feeling you are. So maybe you could break down what the WHI is, what it was about, and then maybe why it was an issue.
Yeah, sure, yeah. So essentially, so HRT was started to become available in the world in about 1960. So for sort of 30, 40 years, women who were usually about 50-ish and were going through the natural menopause if they started to have some hot sweats and flushes, they were usually offered some HRT, and they usually took it for a couple of years. And
This being oral HRT, is that correct?
yeah, so yeah, we used to have most HRT used to be what we call combined oral, so a synthetic estrogen with a synthetic progestogen, all in one easy capsule. But these women, it was sort of noticed in the 90s, particularly. Well, these women that take HRT, they seem really, really healthy and lots of vigor, and they look great, and they're often the ones that are still being physically active. And HRT was popular. Women, wanted to get some of this if they felt they were having symptoms. And then sort of medical trials started to notice actually that women that used HRT actually seemed to have much less heart disease. They seemed to break less bones. And there was also starting to be some consideration that they also seemed to get less dementia. They just seemed to be generally healthier for longer. So essentially, and again, I'm very simplistic about this, but that's how my brain works. The American National Institute for Health, you can understand why they thought it. Thought, well, okay, well, this is great. So actually, if there's this relatively cheap drug that we could give to women, and it reduced their risk of heart disease, well, wouldn't that be amazing? We'd save, gazillions of dollars. Yeah. So yeah, that kind of stands to reason that they would want to look at that. But that's where things slightly started to go wrong, because what actually then happened was that women were recruited in America to this trial, but they weren't around the time of menopause. They were actually much older. So the average age of a woman in that study was between 63 and 64. So they were usually at least 10 years past the menopause. And then they were given the old-fashioned HRT that was popular at the time, but it was quite high dose as well. And they were there was one big arm of the study was women that had still got their womb, and therefore they were having the combined HRT, so the estrogen and the progestogen. And then there was another arm of the trial, which was women that had a hysterectomy, so they were just given the estrogen part. And so they started to watch these women and what happened. And then you can't even make this up. I'm sure there'll be a film about this one day, because it's just such a travesty to women. They started to notice some figures that didn't look quite what they were expecting. Obviously, they were hoping to find that women had loads less heart disease, but they weren't seeing that. It was sort of, actually, was there a bit of extra heart disease in this woman? Wasn't quite sure. And then, actually, there's been a few more blood clots in these women, in their lungs and in their legs. And, was there a couple more strokes? And then, was there a bit more breast cancer in these women? And then, so what actually happened behind the scenes was that some investigators, so quite junior investigators, were looking at the numbers, did some statistical number crunching, but made some mistakes. Didn't go to the senior investigators to talk to them first to come up with a plan, but essentially went straight to the media and the press. And so in 9th of July 2002, suddenly it was announced on the news that HRT was associated with a higher risk of heart attacks, strokes, blood clots, and breast cancer. And it was advisable for women to come off HRT. And literally overnight, about half of women came off their HRT, and then over the next 5 years or so, a load more did. So it just kind of tumbled. But the problem was the statistics was wrong. The conclusions were wrong. So yes, when you actually look back at the data, and I'm not a statistician, but I've I've studied the WHI study for donkey's years, and I kind of feel like I know it inside out. But actually, when you look back at the data, if you look at the very few women that were around menopause age when they started their HRT in this trial, they actually did really, really well, and actually everything was protected and good. And the women, the average women in there, the 90% of women that were much older, there wasn't actually an increase in heart disease. It was neutral, but they got the p-values wrong for the areas of statistical significance. So what it did tell us was, yes, there is a higher risk of blood clots with oral estrogen HRT, and we can now get around that by having different ways of having estrogen. So it did help to show us that. But then the breast cancer, that was always the one that's the most emotive issue around HRT, still is. And this gets really complicated. But essentially, HRT wasn't causing an increase in breast cancer in these women. It was actually, and this is kind of hard to explain, but it was actually women, when you broke down the numbers even more, it was women that had been recruited into the trial that had previously used HRT. They were actually protected from breast cancer. So it made it look like the people taking HRT from scratch were at risk, but in fact they weren't. It was the other group were relatively protected.
So they were conflating variables irrespective.
Yeah.
Okay.
So big, like huge mess. And actually that fear has stuck solid in most people's minds. I mean, I'm one of the lucky ones that has been able to, really look into it. And I know that it's not true, but it's so difficult to take that fear away from people, from the health clinicians themselves, but also from patients. So we have got a generation out there. So my mum's generation all believe HRT is associated with breast cancer. And if they were on HRT, they came off it and probably never restarted it. And they probably told their daughters, like me, not to go on HRT. And most daughters would just listen to their mums because they wouldn't know any better. So we still are trying to reassure women that the association between HRT and breast cancer is still not 100% ironed out. But if there is a risk at all, we are talking about a tiny risk. So around about, this is with old-fashioned HRT. So I'd have to give 1,000 women in their 50s old-fashioned HRT for 5 years for one extra woman per year to get breast cancer who wouldn't have already done so. But we now tend to use more modern sorts of HRT where the risk has been proven to be even lower and may well be very close to zero. And so essentially the risks of getting breast cancer with or without HRT are the same. And actually it's lifestyle we should be looking at. And if we can actually get a woman exercising, not drinking too much alcohol, and being a healthy weight, that has a big statistical impact on her breast cancer risk. HRT has virtually zero effect. So it's trying to condense that into a way that a woman can understand and feel reassured is tricky.
Yeah. That's fascinating. I always was under the assumption, and it speaks to my sort of ignorance on the matter, that there was far more of an issue with the oral progesterones and the oral estrogens.
Yes. Yes, and that was the other complete tragedy. Thank you for reminding me. Is that so? All women came off HRT because nobody told them there was a difference in the results between the combined group and the estrogen only group. So, and the estrogen only group, they were doing brilliantly. They had far less heart disease and far less dementia, and and actually even their risk of breast cancer was reduced. But they all came off it because no one kind of broke down the difference in statistics for another couple of years. So, yeah, complete travesty. There have been apologies since from the investigators, but no one ever publishes good news, or it's just bad news. And
useful knowledge is a dangerous thing.
And there was so much positives in that. I mean, actually, if you look at the data, I mean, the reduction in fractures was impressive. The reduction in diabetes was impressive. All-cause mortality. So in other words, I know this is oversimplification, but your risk of dying from anything went down in the WHI trial, no matter who you were. But it just, that never got any wind behind it at
Yeah,
all.
it never got published. That you it's yeah, like you said, it's nothing sells like bad news. So
Exactly.
trying to sort of refute that is going to be an uphill battle. Dr. Ball, you mentioned this specifically there, this idea of women it's sort of in their sort of maybe earlier to mid 60s getting on to HRT. Now, this was going to be a question I was going to ask later, but we might as well talk about it now. Is there a point at which a woman who has sort of transitioned into menopause or is now perimenopausal should not begin an HRT regimen?
Yeah, good question. So we have a concept now called the window of opportunity, which essentially means that the best time to start HRT is either during the perimenopause, if you're having any problematic symptoms, or within 10 years of your last period, or before the age of 60, whichever comes first. So you could go through your menopause at the age of 56, for example, and actually your window of opportunity then extends to being 66. But unfortunately, sort of myth and Chinese whisper and simplicity means that most doctors and healthcare professionals get very wobbly about anybody starting it over 60. But there are many people who just their menopause was sufficiently late that their window of opportunity is still open. But if we were to use the old-fashioned HRT, what we would think was, well, within that window of opportunity, the benefits outweigh the risks. If you're beyond that window of opportunity and maybe trying to start old-fashioned HRT in a 68-year-old whose menopause was at 50, then the risks potentially outweigh the benefits. But actually, now that we've got newer types of HRT, the more modern types, to be fair, the risks never really start to show up on a radar no matter what age you get to. So the benefits for almost everyone continue to outweigh the risks. There's just not a bigger a difference between the risks, the benefits and the risks when you're still within your window of opportunity. So even if you're much older when you start HRT, you will still get benefits to your bones. We know that for definite. And many, many women will still get improvements in their day-to-day symptoms, which that can then lead on to a much healthier lifestyle and then much greater future health via indirect mechanisms. So, if I've had quite a lot of women maybe in their late 60s or early 70s who are perhaps caring for a poorly spouse and they are struggling with hot sweats and flushes themselves because they've just had that, it's possible for hot sweats and flushes to go on for 10, 20 years, even longer after your menopause. And so they're up and down every hour at night, and then they're weeing a lot because their genitourinary syndrome of menopause hasn't been dealt with. And so actually they're exhausted. They're fundamentally fit and healthy, but they're exhausted because they're getting no sleep and they can't stop weeing, and the stress of their caring role is all accumulating. But I give her a little bit of the best type of HRT. The hot sweats, flushes go away. She sleeps better. Her bladder calms down. Suddenly, she's completely able to do her caring role and actually feels like she's,
human.
She's human. And I know that she's much less likely to trip over and break a hip if she stumbles going to the toilet as well. So we've got another win in there.
Yeah, I think I'm trying to remember the stat particularly, but I think that fractures in people over 60 or 70 is one of the highest leading causes of early death, just because you're going to, you're going to get into the sarcopenic state, lose a lot of muscle mass, and you're then going to have this massive sort of metabolic derangement that then follows, and then as we know now, health is almost all completely metabolic in nature. So if you sort of lose that glucose sink of all that muscle, then all of a sudden you are in a pretty precarious situation.
I think that's difficult as well. So if you're in your mid-40s and you're starting to think about your hormones, the last thing most people at that stage are thinking of is what happens if I fall over and break my hip and I'm 75 and I'm, I don't know, maybe I don't have dependents around who are going to care for me. People aren't on that wavelength. But actually, if you start the process of protecting your bones and your muscles and your metabolism way back in your perimenopause, you shift the dial so much to a healthier life when you're much older. So it's again trying to focus medicine on thinking ahead. And that's what's been another big frustration of trying to get more awareness about menopause in the public arena is that, the NHS, for example, they will worry about their budget for the next 12 months. So they're not willing to spend it on something that could make a massive difference in 20 or 30 years' time, because it's just not, that's not how finances kind of work. But it's a massive public health, option. If you think about all the older people in care homes and residential homes and all the social care that takes up, and, all the heart disease, all the strokes, all the things which could, if you have a fracture as an older woman of your hip, you've got a very high risk of being dead within 12 months, more so than most diagnoses of cancer. And yet we don't tend to think of it as something that's important to try and prevent.
I think that's the term, prevent. There's no money to be made in prevention, is there? You can't sell a drug based on prevention. So it's going to be a complete uphill battle. Dr. Ball, I think we've covered the basics and some of the sort of the underlying physiology sort of really nicely. I'd love to talk about how you work with patients. Now for context, as you've probably gathered, I'm very pro HRT, and whenever I do again counsel a woman, and in that respect, it's sort of just providing guidance as to what they maybe should start thinking about before sort of sending them on to someone like yourself. I always make sure to point out that HRT isn't, as we've just discussed, about symptom relief. It's about health span and longevity, and that these hormones are, as you've alluded to again, are cardio and neuroprotective. And we always have the discussion around lifestyle again, making from that preventative standpoint. And it's always very much grounded in this sort of understanding of getting your metabolic health as good as you can get it. Now, of course, that's difficult for a number of reasons, and I suppose I tend to emphasize the lifestyle and nutrition side of things because as a chemist and biochemist, that's sort of my wheelhouse. So and with regards to that, I'll often point to things like making sure that your detoxification systems are working effectively. Because if you are going to think about getting onto HRT, you want to make sure that your body can metabolize the extra levels of these hormones effectively. So if there's impaired sort of phase 1 or phase 2 detoxification, you've got an issue with glucuronidation or something like that, maybe taking in using HRT at that point in time is maybe not the best strategy relative to sort of improving your health, and then considering getting onto HRT when you've got those basics sort of taken care of. Now, I have a bunch more questions relating to testing, and of course, I'm no expert here. But what do you think of that sort of as a model? Do you think that we should, I suppose, as a community, be educating women on their health in general before starting HRT, or do you find that it's best just to get someone who is struggling onto a protocol, and then sort of maybe dealing with these other sort of this minutia after the fact? Does that make sense?
Yeah, it absolutely makes sense. And again, I think that is maybe a journey that we're going on with the more public conversations now about menopause, is that traditionally we've had women make their first call to someone like me because they're in a real pickle in the throes of perimenopausal or menopausal symptoms, and they are maybe sweating every hour, can't sleep, anxious, relationships are falling apart, they're so achy that they can't, the thought of going to the gym is completely not on their radar. They are depressed, that they are rock bottom, and we chat to them and we go through all lifestyle issues. I want to know about what is their sleep like, do they snore, what is their diet like, what is their bowel habit like, what is their movement, do they have any movement in their life at the moment, what are their stress levels. I want to know, past trauma, I want to know all that stuff. But for each woman, I will treat her completely differently. So there's some that I just need to put a bit of, or invite her to put a bit of estrogen in the system, just to kind of, if we could just get rid of the sweats to start with so that she can sleep. We all know how dreadful it is to be sleep deprived. It's a form of torture, isn't it? And then, sometimes just a couple of weeks later, they're like, it's almost like they're coming out of, a fog. And then we can then plan a more strategic way forward, which is about the bigger jigsaw. So I always, whenever I'm seeing anyone, I'm thinking about a jigsaw. Yes, I have the ability to put the HRT in place. And for some people, that's a big part of their jigsaw. For some people, it's a very small part. And for some people, actually, it doesn't need to be a part at all. So, there are some people where and again, I am, so just to be absolutely clear, I'm a medical doctor, conventional medical doctor, but I have done quite a lot of extra learning of my own volition about diet, nutrition, functional medicine, genetics, particularly. I'm looking at people's DNA. And you just realize that, I could see someone and they'll come maybe and they'll say, just really depressed and I'm achy and maybe a bit overweight. Maybe there's a bit of thyroid issues in the family, for example. And then I'll say, okay, do you take, what's your diet like? And do you take any supplements? And they'll say, I've got a bit of a rubbishy diet because at the moment they've got no energy or creativity to cook from scratch. So they're having takeouts or whatever, and they're not using any supplements because, they're a waste of money, in quote unquote. And
some of them are.
Yeah. And they go, okay, do you take any vitamin D at all? No. And they work in full time in an office or whatever. And sometimes I just give them some vitamin D. And then they come back a few weeks later and go, oh, that was miraculous. And then sometimes they don't actually need HRT for a while longer, because actually they were lacking in vitamin D. But again, the NHS doesn't really deal with that particularly brilliantly either. Or, sometimes their thyroid's completely up the spout.
I was going to ask about that because obviously I have a better understanding of male physiology when it comes to the sort of the thyroid testes axis, but oftentimes if you've got that downregulated thyroid activity, the pituitary is not going to in any way, shape or form send out sort of LH or FSH signaling to the testes to then start producing testosterone. But the moment you flip the switch on the thyroid side of things and you get that thyroid signaling back, not only does the HPTA start working properly, but then at a mitochondrial level, you're able to start producing these hormones more effectively within the testes, within the Leydig cells, within the Sertoli cells. I assume the same logic sort of carries over to women as well. If you can correct a thyroid issue, can you sometimes maybe just offset the need for other forms of HRT?
Yeah, absolutely. And we do sometimes see this where people will come to me and they've been on HRT for a few years and they've just never really had that much improvements from it. You're trying to, it's like being a detective the whole time. You're trying to work out where can we change things for this person? And then you'll look and you go, oh, actually, well, there's a family history of thyroid issues, and actually you're maybe a bit overweight, maybe there's been no vitamin D in the equation. And I'm thinking, I don't think the thyroid's working brilliantly. And they will sometimes bring to me their NHS blood results, and you'll see that actually their TSH, it's within the normal range, but it's most certainly not a TSH that I'd want. Yeah.
9, 10.
Yeah. Or even like 4. And I'm thinking, well, okay, technically it's normal, but I'd much rather it was a lot lower. And then you maybe check their autoantibodies or whatever. And if I think that's maybe why being a GP is quite helpful in this job, because you can see that, I'm not brilliant at thyroids, but I know when to call someone in that is, if you see what I mean. So I'll say, with this, your history and your symptoms and your blood results, I think we actually might need to treat you as if you have an underactive thyroid. I stay in my lane and I do the hormones, but I will make sure I send them to someone that I trust to look after that bit of them. And equally, I've having learned a bit about the nutrigenomics. I mean, that's a complete game changer in terms of even just being able to show a woman to say, look, this is cholesterol here, and it comes down this pathway and it makes some progesterone, and then it comes down this pathway and makes some estrogen. And look what happens if your stress goes up. It basically steals it from that progesterone, and your progesterone is going to your GABA receptors and giving you all this relaxation. So you can really start to, and not all women need that. Not for 1 minute saying they do. It's a lovely thing to have if people are in that situation that they can access it. But it can really answer a lot of questions and really help women. We have a lot of new diagnoses of ADHD and things at this time of life, because once the estrogen drops, the poor old nervous system then wobbles like never before, and women just don't know what to do with themselves. And then when you can help to explain how this is all a series of complicated cogs, and if your big methylation cog at the center of everything starts to slow, which it will with age, and then a bit more with menopause, then something else is going to reach a critical, or drop below a critical threshold for working, whether that's your neurotransmitters or your thyroid or whatever. And then we get all the women with the histamine issues who come, and they've always been fine, and they get to their 40s and suddenly they can't control their hay fever, and they've got hives, and if they have one drink of wine at a wedding, they like flush and faint and fall over. And
estrogen dominant ones, I assume.
Yeah. And so just, and I am no expert in it whatsoever, but I have an absolutely fabulous colleague that I send them off to, they just say, oh my God, this is so empowering. This is, to actually be able to explain to a woman why she's always felt like she has, or why things have got much worse recently, or whatever, is, it's a complete game changer for some of these women, whether it's their thyroid we uncover is the issue, or their nervous system, or they've got adrenaline receptors which are like on high alert, or or their cortisol, the biochemistry is all very messy. Then it's amazing. So it's made my job so much more rewarding, because you can start to, and I send a lot of women also to a lovely colleague of mine who is a breathing practitioner, and we either to stop them snoring, or we send their partner, if that's because it's almost as bad sleeping with a snorer as it is to be a snorer in terms of your health. It's lovely to be able to try and work out, so I've never got the same formula for any two patients. It's always a different journey.
I was going to skip over this, but then you mentioned genetics, so I'm sorry you shot yourself in the foot a little bit there. But testing, I assume going into, well, actually, this is a good question. Are you doing a lot of testing off the bat, or do you just sort of go off symptoms? Because I assume if somebody's coming in with these perimenopausal symptoms, you can be sure that things like FSH are going to be through the roof and AMH is going to be all over the place. Do you sort of worry about that straight off the bat, or are you
really, really individual? So usually, again, I'm generalizing somewhat, but a lot of women that come to me for the first time, if they're not already being treated for their menopause, are in quite a state, or they can be in quite a state. They might not be able to retain any information because their brain deserted them long ago with brain fog. They're usually really anxious to actually have the conversation. They're tearful. They feel like that they're completely losing it, and it must be that there's a massive problem with them. And then I can listen to them and explain, actually, you are, this is absolutely classical of your changing hormones, and I can explain why that's all happening. But then if there'll often be things they throw in, and I think, oh, it's almost like you can sort of see their genes beneath their skin. It's like, oh, I bet you've got that gene, and I bet you've got that gene. But I usually, not all the time, but usually won't throw that into a first consultation, because it's too much information. But there's some where actually they've already been to a million different providers. They've already researched their own condition, upside down and inside out. And I do feel that they've got the capacity on that day to talk about it. And so I will say, look, there is this other test that I could send you for, and I have to say, it's private. It's not cheap. It's not cheap at all. But, actually, if money were no object, then wouldn't it be great if we all had our DNA mapped out the day we were born, so that we knew what our vulnerabilities were going to
full
be?
genome
Yeah,
sequencing was
yeah,
amazing.
wouldn't that be amazing? But I know most people aren't in that privileged position. But there's lots of people that I might not even need to think about it for, a couple of years, where we've got this right and that right. I've had a woman recently who starting HRT was quite helpful. She became a lot more healthier, was brilliant with exercise. That all got a lot better. We could not, despite she brought her BMI down to normal, she was generally doing really well, but we could not get her HbA1c under control, and no family, I couldn't work out why it was, but so eventually we got her genetics done, and she has got all the dodgy glucose processing genes, and so now she's on, rather than the more generic supplements that I might talk about with them, she's now on a very much more individualized regime. And
Did
now
you reduce her carbohydrate intake alongside that?
Yeah. Oh yeah, she's so on it.
What genes are you looking at specifically, and are you doing things like a Dutch test? Are you doing more of a generalized DNA test?
Yeah, I don't. So again, we don't do them within health and menopause, but we send them to somebody that we've worked with for a long time, and that is a menopause specialist themselves, and therefore understands the intricacies of what we're trying to achieve. And so we really individual. So we might do, nutrient core and methylation are often really helpful, but a lot of our patients, we do their hormone, their estrogen pathways as well. They might want their metabolics doing, especially if weight is an issue, or cholesterol issues, or, we think there is sugar processing issues. Histamine, a lot, yeah. Although often you do find that the histamine is only the tip of the iceberg, and it's usually a methylation issue at the heart of the problem, as from my unexpert, my
No, you're right on the money. When you've got impaired histamine processing throughout the body, it's quite often the case that that individual is potentially estrogen dominant, and that individual is potentially estrogen dominant. You've got to start looking at, well, why aren't they clearing estrogen effectively? Which is why I think these tests are so interesting, because they can also then govern, I think, the way that you potentially would treat somebody with an estrogen. Because if they aren't very effective at clearing estrogen from their system, then maybe you won't sort of bias and the therapy towards being completely estrogen dominant.
Yeah, let's shift your constipation first. There's absolutely no point putting a load of estrogen in the top if it can't get out the bottom, because that's going to be toxic.
Definitely.
That's my very simplistic look at it, and it's helpful. We also at Healthy Menopause, we actually also specialise in helping women that have a history of cancer, or any type, but particularly breast cancer. And so, again, sometimes if you can look at how someone is clearing their estrogen through, their 4-hydroxy pathway or whatever, it just gives you a little bit more information to be able to more accurately direct an individual rather than a population of women, if you see what I mean.
It's very much an individual level. Dr. Ball, I'd love to talk about estrogen management all day, but for the sake of time, I'd like to talk about the elephant in the room, and that being the use of testosterone in HRT. Now, I don't know of any medical governing body in the UK or abroad that advocates for the use of testosterone replacement therapy in women, or TRT, which I think is a little absurd, because it's a hormone that is, well, naturally produced in woman, number one, and B, is crucial to, well, life, just being sort of happy, functional. I mean, if you look at the sort of the Adams questionnaire for men for low testosterone, I mean, the same things apply to women as well. Sort of low libido, low mood, dysregulated insulin sensitivity, poor metabolic health, and inability to maintain and hold onto muscle, etc., etc., etc. Now, as I mentioned, there are, of course, no no governing bodies approving this, so there are no guidelines on the use of testosterone in women's HRT, which again I think is daft. I'd love to get your take on this though. What do you see in clinical practice when a woman gets onto testosterone or some sort of TRT therapy as part of a well-designed protocol? Is it generally a needle mover, maybe when they haven't had that much success with just manipulating estrogen and progesterone levels, or is it just another cog in the machine?
Yeah, it can be a complete and utter game changer, literally like flipping a switch between night and day. For some people, it's, yeah, definitely had some benefits. It's not a game changer, but it's definitely been helpful. Some people doesn't actually help much at all, and very occasionally some people find they feel worse with it. But in general, the positives are so much more numerous than any negatives. And so the NICE guidance says that if a woman is, well, they're supposed to be postmenopausal. If a postmenopausal woman is settled on HRT, and the HRT is essentially sorting out all of her menopausal symptoms, except that she still has a low libido, which she finds distressing, and for which there is no other obvious cause, then we're allowed to consider a trial of testosterone transdermally, so through the skin.
Yeah. But only for low libido.
Yeah, only for low libido. The kind of then the joke about that is that you go, oh, okay, well, this woman actually fits all those criteria, so let's go. And they go, well, what are we going to use? Oh, we don't have a licensed female product in the UK for this. So what are we supposed to do then? So then the woman then either has to go privately to be able to access. So we have Androfem, which is a testosterone cream that comes from Perth, Australia. So we've been using that in the UK under MHRA guidance because we're allowed to import it because we didn't have our own product for, I don't know, probably a good maybe up to nearly 10 years now. Now, it actually got its license a week ago, which is brilliant, amazing. Although, of course, in practice, all that means is that now NICE will maybe look at it as a possibility, but of course it's really expensive. So I'm afraid I'm not holding my breath thinking that it's actually going to be available on the NHS anytime soon. Maybe a couple of years, but the other option that women have is to have one of the male testosterone products, but it needs to be prescribed at a female dose, which is approximately 10% of a male dose. Now, of course, I can do it in my sleep because that's all I do day after day, but most healthcare professionals aren't used to doing it. And that's where we see mistakes happening and women being given the wrong doses.
Androgenized.
But it is... it's, when you explain to women and say, look, when you're in your 20s, your late adolescence and your 20s and early 30s, you had loads of testosterone, far more testosterone actually than you had estrogen. And then from your kind of early to mid 30s onwards, it just gradually started to decline. And it was nothing, it was maybe 1-2% a year, not that much. So maybe by the end of your 30s, you're thinking, well, okay, my libido's not as good as it was, but, maybe I've been with my partner for 10-15 years, we're not swinging from the chandeliers anymore. We've now got kids and jobs and stress and people. We're more worried about who's emptying the dishwasher than what sexual position we're going to do tonight. And so it's subtle and most people don't notice. But I also think there are some women out there where when you really carefully go into their history, their chronic fatigue syndrome or their fibromyalgia or their depression that seemed to come out of nowhere has come about around that time, and we've tried all other kind of ways of treating it, and actually then you add the testosterone and it's like bingo, that was what the problem was. There was no testosterone in the system. So testosterone is not, for most women, is not actually about the menopause. It started before the menopause started to happen. It's just that by the time you get to your menopause and your estrogen and progesterone have also gone right down, I think it's more exposed that your testosterone's low. But then, of course, we have got the women, the younger women that have the premature menopauses. They often really do well with testosterone because they're, still much younger and, kind of need that extra energy and stamina. And then the women that have a surgical menopause where their ovaries are removed overnight, they lose 50% of their testosterone in a bucket overnight in the surgery. So they often do really well with it. And when you actually explain to women and say, look, all I'm doing is giving you back a hormone that you've had in your body since puberty.
Since the adult,
Yeah, and I'm only giving you back I'm giving you 10% of what I give to a man. And we will actually measure it in your blood just to prove to you that you're still, female. And the worst thing that could happen is you'll get a bit of acne back if you were prone to acne in the past, or a few darker hairs, and then it's reversible. You stop the medication, it comes back. So it's amazing. And actually, the problem with testosterone is that we don't have enough evidence in terms of worldwide big enough randomized controlled trials to prove that it's effective for anything apart from low libido. But from a day-to-day point of view, we see it all the time. People's mood gets better, their stamina gets better, they can work out, I definitely, when I started testosterone, I was training a lot anyway physically, but when you're measuring everything on a Garmin, every spin class and every run, and it clearly jumps up a massive notch from using physiological levels of testosterone, you go, well, why would anyone not want to try this? But we don't have, there is no data out there because no one will fund the studies. The British Menopause Society just a couple of years ago put in a bid to say, look, we want to see, does this help, bone density and muscle strength and mood? No one will fund it. Now, quite, I'm not going to get on my political high horse about
it's all right. We can get on a soapbox or two.
Misogynistic, political, and people say, what would the world look like if women had the same rights as men to having their own physiological setup restored to them at this time? There's some stupid quote, isn't there, about there's more CEOs in the UK called John than there are female CEOs in total. It's that sort of stupid, it's like, well, why is that? It's because we fall off our perch, and you started the podcast by talking about, what is our use after menopause. I'm a big fan of the grandma hypothesis. So, that families, and they found this in, I think was it dolphins or whales? I think it was whales, that the families with a grandmother in them had far better survival rates. So the children did better, the grandchildren did better with a grandma, because, they're and to make a grandma, you need to make her unproductive. So you've got to stop her reproduction so that she can just concentrate on looking after and nurturing and baking cakes and cleaning up and things. So that's my kind of slightly nicer take on why we have the menopause. But actually, now we live in a society where women have to keep working. We can't just not work at all or stop work when we get to 45. And so, testosterone can be a massive benefit. But then equally, with some of my ladies that have had genetic testing doing, you actually see that if they have the genes which mean that you turn your testosterone a bit too readily into estrogen, and they're already a bit estrogen dominant, you'll find that they don't feel any better. In fact, you wobble their nervous system a little bit more.
Would you not maybe blunt that with some sort of compound like aromacin or arimidex to sort of...
I think that I have certainly heard of that. That's way beyond certainly my scope, and maybe I think that's maybe more in male kind of medicine, but it's certainly not something we're doing.
Okay,
with women.
You're not trying to actively manipulate aromatase activity.
Not usually, no. Obviously, some of our breast cancer patients may be on an aromatase inhibitor, but we wouldn't normally. We'd be looking more at the kind of dietary ways of doing that, or some,
DIM and all of that sort of stuff.
Yeah. Okay. Although, of course, I'm a big fan of just I get them sprouting their own broccoli.
Fair enough. Yeah,
as a starting point. Yeah.
Perfect.
And it also brings. Sorry, do you mind me just mentioning?
Yeah, of course,
also made me think something you said earlier was that convention says that HRT is about estrogen and progesterone, but actually, now that the pendulum has sort of swung with menopause and it's more of a common conversation, I do get women coming earlier and earlier now. So they might be in their early 40s, and then they might not be in too bad a place, but they're coming, in a proactive, preventative way, which is brilliant. And sometimes when you talk to these women, they're just getting the symptoms of low progesterone at that point. So their sleep's gone a bit, their menstrual cycle's changed a little bit, and they're getting anxious. but actually they haven't got the hot sweats and flushes. Their joints are still okay. They haven't got the genitourinary symptoms. And so for some of them, you can just give them some natural progesterone. Bob's your uncle. They feel great for another few years. And then you just, as long as I say to them, at some point, you may well need some estrogen, but, we can do this in a very gradual journey. I think progesterone has been completely overlooked as well. Testosterone has been overlooked and progesterone has also been. We've concentrated a bit too much on estrogen, although it is a brilliant hormone.
Yeah, it's so much easier being male. All you've got to fundamentally do is just, right, so what do you need? Testosterone. What's going to happen? Worst case scenario, you're going to over aromatize it. Okay, we'll give you a drug for that. And then you can just sort of tweak one or two variables until you get it right. Yeah, maybe you've got to look at the thyroid as well, but it is definitely simpler. Dr. Ball, I'd love to sort of maybe touch on some of the DHT stuff in a second, but first, what are your thoughts on DHEA? Now, I mean, obviously women produce testosterone, as you alluded to earlier, either in the sort of the ovaries or the adrenal glands, and some women are going to naturally be biased towards or inclined to produce more testosterone in the adrenal glands versus the ovaries, just based on their genetics. Now, one would assume that if a woman is predominantly a producer of testosterone from the ovarian standpoint, that when they get to menopause, that's going to go away. But for a woman who maybe has more of a bias towards producing testosterone from the adrenal glands, would a compound like DHEA is it a compound like DHEA that is fundamentally a hormone precursor be an effective option in these sorts of women, or is it a bit hit and miss?
Yeah, so I only prescribe what I call body identical HRT. And what by that I mean it's bioidentical, as in it's molecularly identical to our own hormones, but it is regulated. So it's all, via the MRHA. So it's the standard kind of things that can be prescribed. Some private clinics do what we call compounded bioidentical hormones, where it's kind of sort of made to measure, but it's not regulated. So I see the role of it and why it's cropped up, but I don't support that because it's the safety data isn't there because it isn't regulated.
Okay, so pro hormones aren't a thing for you then?
No, but I do understand why they're there. But from my training and my
the way you practice,
the way I practice is that it's the regulated stuff. But we do have DHEA in a regulated vaginal pessary, which can be highly effective if just using estrogen in the vagina or vulva isn't helpful. So yeah, the pessary, but again, this, but the simplicity of it is that it essentially turns into estrogen and testosterone in the cell. Therefore, you're sort of getting, I always want to say you're getting two hormones for the price of one, but in fact, really, you're getting two hormones for the price of two hormones privately. But but it's, so that can be helpful. But I do have patients coming to me from bioidentical clinics who want to change to the regulated stuff, and often they are on DHEA, but I don't prescribe that. So I do see that there's a role for it because everyone is different, but in a world where a lot of the guidelines and the MRHA deals with, this is the guideline and it's got to suit everyone. I sort of explain, well, you're not losing too much by losing that DHEA because we're going to give you the estrogen and testosterone. It's just, but it's, I recognize there's a much more detailed minutiae underneath that, but, we're
outside of your scope of practice, and that's understandable. Fair enough. Okay. DHT. Obviously, I think that's what most women are worried about when you mention testosterone. And of course, just for the audience, what testosterone is it's a hormone. It's a quote male hormone, which I don't like because hormones are hormones. I suppose they have a secondary sex characteristic development attached to them, but a hormone is fundamentally does the job. But what testosterone does is it's converted by an enzyme and a gene called 5-alpha reductase into DHT. And now DHT is this very adrenergic. I've got that right. No, not adrenergic. That's
Androgenic.
androgenic.
Yeah,
Thank
that's
you.
where you get the acne
Hormone.
and the
Yeah.
yeah.
Hormone that then drives a lot of these sorts of issues when it's in excess. Now, a certain amount of DHT is definitely very healthy, and it helps with mood and executive function and all of that. But excessive amounts can lead to hair growth, hair loss, sort of widening of the jaw, all sorts of things like this, deepening of the voice that are definitely not wanted, especially among women. When you are sort of working with a woman on testosterone, are you? I think you did mention it, but are you looking at maybe any of these genes? Are you looking at ways to maybe modulate this 5-alpha reductase expression so that you can control that conversion of testosterone to DHT? Or
yes, if I had a woman come see me who had struggled in her life already with quite bad acne, then that would
PCOS and stuff, yeah.
that would give me the clue that they probably do convert quite a lot to DHT. So there's no harm in trying the testosterone. I might do half the normal female dose, and we would just see, and I would reassure her, if your skin erupts, you just stop it and it will come back out of your system. It's not irreversible. But then if they have the ability to, we could look at your genes, and then we could look at more dietary and lifestyle ways of trying to manage that gene as best we can. But I mean, I always remember that lecture when I was doing the training about that some of the testosterone goes to is it adiol? That
androstenediol.
Which for some people is so relaxing. So I've had patients that their primary issue is anxiety, and we've done everything else. We've given them progesterone, we've given them some estrogen, we've looked at counselling, we've looked at nutrient, we've kind of done everything, and then you just give them a little bit of testosterone, and suddenly they go, "Oh, why did you not give me that ages ago?" And I say, it's because you were too anxious to have it. Remember, we've had all these. But again,
There's obviously the link between testosterone and dopamine as well. And the more dopamine you have, Bob's your uncle, you're going to be in a far more sort of parasympathetic rest and digest state. So I'm sure that plays into it as well. What about things like, I'm sure I know the answer, but compounds like saw palmetto? Have you ever utilized something like that?
Again, it's one of those where I've heard about it in the lectures, and I understand that it's all to do with the testosterone thing, but I leave that to the nutritionist to actually, I'll talk about basic supplements with them. But then when we're getting that individual, then I say, look, I'm not actually a nutritionist. I'm sort of signposting you towards one.
Fair enough. Dr. Ball, this has been a fascinating conversation, and you've been an absolute star. Before I let you go, though, I'd just sort of love to run through a few rapid fire questions, if that's okay. And to start off with, what is the one lab test every woman should on HRT should get or consider getting, in your opinion?
None.
Fair enough.
Apart from if she was on testosterone, we would have to monitor that because the guidelines say so. But the rest is all too misleading.
All right. What's your one negotiable lifestyle tip for women on HRT or considering HRT?
All of them, but movement, I suppose, is my
go-to.
Yeah, it's my go-to.
Fair enough. Okay. The biggest misconception about the use of testosterone for women?
That it will turn you into a bearded lady. It will not. I don't know how many tens of thousands of prescriptions I've done for testosterone for women. Never had a problem.
So you're telling me you're not prescribing 100 milligrams a week?
No.
Fair enough. And does HRT need to be titrated down with age?
Usually, yes. So in general, you'll need to go up as you head towards the menopause, plateau for quite a while, and then generally tend to come down again, but not till, on average, I would say if I was giving a 50-year-old a normal dose, I might reduce that by 25% at around 60, and then another 25% around 70, and then another 25% around 80, so that they're just on a smidgen at 90, but they've made it to 90 and they're still banding up the stairs to clinic. So,
Perfect. Dr. Ball, you've been a star. Thank you so much for your time, and hopefully we can do this again soon.
Thank you, Rob.